Real quick. All right. Hello and welcome everyone to a webinar. This is going to be the first webinar of many we're doing throughout the season, about once per month. This one is going to be on how to succeed in your EM Sub-I. Woo! Super exciting. So we are Harbor UCLA. We'll go in a little bit more into our program, and then we'll do introductions of all the wonderful people who are on this chat a little bit later, but we want to jump right into the meat of things and get you all some tips and tricks that'll help you throughout your rotations. All right. So kind of the basic structure of this talk is we'll talk about number one, kind of before your rotation, what to do, what to prep. 2, starting on your first shift ever. 3, what you do on said shift. And then 4, we'll talk about the end of your shift. And then at the very end, we'll do kind of Q&A and talk about Harbor a little bit more. All right. So before the rotation, first thing you got to do is you got to get pumped. You worked so hard to get yourself into this space. You submitted the stupid BLSO application that has 17 million requirements and all the immunizations. You finally got to your sub-I. Get excited. Like, sub-Is are really fun. This is kind of where you get to show your stuff a little bit, try out a few new things. So one of the things we recommend is kind of knowing what type of hospital you're going to, because every type of hospital is a little bit different. So county, we are a county site. It's kind of more of a safety net hospital, underserved community, limited resources, things like that, versus an academic site is going to be very different, where you have lots of consultants and things. And then community is kind of more like push patients, keep it going. So knowing generally what you're walking into is helpful. Knowing the number of shifts, types of shifts, that's also very helpful, kind of like the types of shifts we throw in, kind of like nursing shifts or EMS shifts, just kind of being generally aware. One huge recommendation I have that was given to me when I started my sub-I rotations that I highly, highly recommend. The EM Clerkship podcast has a series on how to crush your slow. So basically, he goes through 30 tips, and each tip only takes about 3 minutes, basically. And he gives like very, very like high yield tips on how to crush your slow. Like, it can be very simple, like make sure you introduce yourself, but it's like how to introduce yourself, like how many times should you introduce yourself, when's a good time, place, things like that. So all those nitty gritty details, super duper helpful. Definitely, I know some of you probably have already started your sub-I rotations. It's never too late. I definitely recommend. I'm not sponsored by him in any way, shape, or form. It's free online. Just Google it. How to Crush Your Slow, EM Clerkship podcast. It should come up. Also, there's a whole bunch of really good on-shift resources. This is kind of my top 4 highlight if you're going to download something, or top 3 at least. First one is MD Calc. So as emergency medicine doctors, we are obsessed with evidence-based medicine. So we love having like little scores and things like that we can support our clinical rationale, like the heart score, the PERC score, Wells score, things like that. Having it at the touch of your fingertips on an app, super helpful, or even just pulling it up on whatever computer you're working on and incorporating that into your presentations. We love to see it. WikiEM, also absolutely wonderful resource. This is like our humble brag moment, because it's hosted based out of Harbor. And so as residents and faculty, we contribute to it. It's really great online resource. There's an app as well. Type in kind of any general like pneumonia or UTI, and then you can get the dosages, antibiotics, things like that. So very helpful. Lab tests to order. So it can help you also make your presentations, among other things. Another one is Hippocrates, that can help with medications. And then if you're doing specifically a pediatric EM rotation and you're going into EM, this one's $5, but it's like a $5 well spent, because you have all of your dosing for pediatric medications right on the touch of your phone. So that's also super helpful. But definitely MD Calc and WikiEM, I think, are 2 must-haves on your phone, and they're free. Woohoo! All right, so that's before rotation. Also, another thing is a lot of people kind of get really stressed out, being like, oh my God, I'm going to be a sub-I now. Like, they're going to expect so much of me. Like, I need to know literally everything. Definitely not the case. We understand where you're coming from. Just, I think, setting up a study strategy a little bit early on if you can. So for example, if you know that you're going to have a 30, 45 hour-long commute every single time, loading some podcasts or thinking of podcasts that you want to kind of cover before on your way to shift or after your shift. can be helpful ways to kind of just do passively studying. So EM Basic, EM Clerkship Podcast, MRAP, unfortunately you have to buy the EMRA membership, but it's about, I think, $60 for students. Could be worth it, something to look into. I hate that there's so much, you have to pay so much for all these random study resources for like Step 1, AMBOSS, all of that stuff. So MRAP, plus minus, it's a little bit more in depth and more helpful for residency, but if that's something that you want to try out, it's definitely a good resource. Other ones, Rosh Review, AMBOSS, Case Files. At this point, you've done clinical rotation, so you know generally what works for you. Anki, just continue doing what's worked for you in the past. Okay, cool. So that's all kind of before your rotation. Prepped everything, you know where you're going, you know what's up. Now it's kind of starting your first shift. First and foremost, show up early. Make sure you have time for parking, make sure you know where you're going, where you're supposed to be, things like that. Just give yourself ample time, especially that first shift, to kind of figure things out. Also going in the future with residency and things, people always appreciate residents that come a little bit early and pick up those last few runs, and then everyone remembers the person who comes 5 minutes late and a not so hot light. So always showing up early. Be nice to literally everyone. Like, not just attendings, residents, you know, kind of be like, oh, hello, you know, and then if you're like super mean to like housekeeping staff, like that's not the type of person we want to work with. We want someone who's absolutely nice to everyone, willing to help out anyone. Nurses, techs, EKG techs, CT techs, like everyone in the hospital. Like EM is a very team-based approach, so you got to be nice to everyone on the team. Expect that every shift will be different. So unlike some of the inpatient rotations where you have like one team that you do a lot of the same things with, the same attending at least for like a week at a time, every single shift will have a different hodgepodge of patients. It could be at a different time, different set of patients. For some reason in EM, things come in batches. So it'll be like your ortho day or your chest pain day, but everything's going to be a little bit different. Introducing yourself to everyone at the start of the shift is also important. So I wouldn't necessarily go ahead and like shake hands with every single person and be like, hi, I'm so-and-so, hi, I'm so-and-so, because that's a little much. But making sure to kind of like read the room, figure out when's a good time and place to be like, hey, I'm so-and-so, like I'm a medical student, happy to help in any way. Just like a really quick introduction so people know who you are and that you're like ready to go. Also, if it's not too busy, especially at the start of day shifts, asking like, hey, what are expectations you have of me on this shift to the attending and resident that you're working with? And if you have any specific things you want feedback on, that can also be very helpful to just kind of like put it up front, be like, hey, I want to learn about X today, just to show that you're always trying to improve. Lastly, make sure you see patients. That's why you're here. We absolutely love you to see patients. It's gonna be great. Cool. Once again, be nice to everyone, literally everyone. Can't stress this enough. We've had people in the past who are like pleasant on one side and then they're mean on the other. It comes around to haunt you. And this should be just your motto for life in general. Anyway, moving on. Great. So now I'm going to hand it off to Naresh, and he's going to talk a little bit more about tips and tricks for on shift.
Hi, everyone. My name is Naresh. I am also one of the PGY2 residents at Harbor. It's nice to meet everyone. So for this next part of our webinar, we're going to kind of talk about how you go about your EM shift. And we're going to try to keep it as general as possible, not knowing where everyone's doing their rotations. Some students have had the opportunity to rotate in the emergency department as a MS2, MS3, but as an MS4, there's a little bit more expectations of you, and you sounds like you want that going into a sub-I. So go into every shift with excitement and ready to pick up patients. So we're going to go through step by step kind of how your approach to a day should go. So at Harbor, we'll generally prompt students, hey, there's this patient, go see them. Or if you're really interested in the type of pathology, then you'll pick up that patient. And we have an electronic EMR. Some emergency departments are still functioning on a chart-based system, and you just pick up any random chart. So when you go to pick up the chart, ask if it's okay to go pick up a chart. If someone says, wait a second, let's go see this patient, maybe there's someone sicker, something more interesting, and they want you to go see them. So just keep your preceptors in the loop with what you're doing and don't move charts from where they shouldn't be unless you're seeing that patient. Day one, make sure you know where you're at, know where the rooms are, be very comfortable in the environment you'll be working in for the next month. And then if there's any procedures that you're really, really interested in, let the senior or attending know day of, and hopefully they can make opportunities for you to do it. And a great, 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 great one that's always helpful for everyone is suturing. So this is a big point. It all comes down to attitude when you're on these sub-Is. If you are very, very eager, want to see patients, want to help the team, be that team player, feel out the room, understand your role on the team, and advocate for yourself to do what you want to do to learn, but also work with the team and make sure you're reading their needs as well. So when you review the chart, it's not a full chart biopsy where you read every single thing about the patient since the beginning of time. You're going to get a small snippet of why they are there. So try to read through the chart quickly, understand why the patient is there, their past medical history, and kind of have an idea of what you're going into and their chief complaint. The idea of emergency medicine is the undifferentiated patient. We don't ever know what we're going to see on any given day. Every patient is going to be different. And that's what kind of makes it exciting. And I hope that you guys are excited for that as well. Number one is to review those vital signs. Sometimes they're written there, sometimes they're on the board, on the EMR. If you're uncomfortable with those vital signs, or if you don't know if those are uncomfortable vital signs, ask. Ask immediately. Make sure your preceptor is in the know of who you're seeing. And if they look sick or if those vital signs look really, really bad, tell the attending or resident immediately. And if you're unsure, let them know. So start with the chief complaint. And if you listen to those podcasts, some of their advice is once you read a chief complaint, start creating your differential diagnosis. That's going to start cutting down on the questions you need to ask. You'll know which are the pertinent positives and negatives that you need to go into that room with. Same thing goes for physical exam. So you, on medicine or other rotations, you might do a completely full, thorough physical exam of every system. Sometimes you don't have the time for that in the emergency department. So you need to know which portions of which exam are the most pertinent for the chief complaint you're trying to understand. At the same time, if you have the time, you can do the full physical exam, and we'll talk a little bit about presenting and what parts to keep for yourself. And if you're prompted, you can always bring those up. So ideally, visits in the ED should be 10 to 12 minutes. That is very, 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 very difficult to achieve. So take your time, go build the rapport with the patient. You're taking this patient as your patient, so they should be very comfortable working with you. If you can get it done that fast, that's great, but take your time, make sure you're thorough and complete, and make sure you're addressing their concerns, because ultimately that's what's going to shine through. Eventually your resident or your attending will be seeing the patient, and they will relay over how they felt about you and kind of the experience that they had. And you want that to be a positive experience. Try to keep your questions focused. What I like to do, and a lot of our residents do, is start with an open-ended question. What brought you here? Let the patient really explain that to you, and then you can ask directed questions to pinpoint the diagnosis that you think you're heading towards. As they speak to you, you can change your differential, and you should always be thinking about the differential. As a medical student, you will almost always be prompted, what is your differential and what's your highest? And we're going to kind of talk about how to order that in a second. For your physical, think about what parts of the physical are very, very important. Sometimes, listening to bowel sounds may not be what you need to do. You can do it, but you may not present it. And then bedside ultrasound. Be very, very comfortable with ultrasound. Most emergency departments will have one. And residents, attendings will be very, very impressed if you're able to do ultrasounds. Generally, we like to go with our students to perform them together. It's always nice when they can teach us a thing or two too. So the presentation, this is kind of the meat of the journey. This is what everyone's waiting for you to do, and kind of this is where you can really shine. So there's a couple outlines. There's a Vimeo here that we can post in the chat so you guys can take a look at it. And there is basically, you want to start with a one-liner. Hey, this is so-and-so age with this past medical history. And I think that they're pretty sick and they look uncomfortable. And this is what I think is happening. Then you kind of talk about the HPI, what you did in the room. So your physical exams, you don't have to include everything. If you have a pertinent exam, like there's positive Murphy sign, then you can bring that up first if you think it's like cholecystitis, right? Include your vital signs. I know as a med student, I'd always forget to bring that up. And then you want to talk about your differential diagnosis. Now, this is where you're going to be tested. Everyone's going to want to hear your thoughts on this. At Harbor, we like to use the model SPIT. That's going to be, you start with the scary things that this can be is, an MI, aortic dissection. But most likely, I think that this is GERD. Other interesting things, this could be rheumatic heart disease. I don't know. And then you want to anchor down on a treatment plan. What do you want to do with this patient based on what you think it is? And, full send that. Just, it's okay to be wrong. That's why you're here. That's why you're a med student, you're learning. And that's the opportunity for the resident or attending to refine the presentation. It's always impressive when a medical student can say, this is what I want to do. And this is what I think we should move towards discharge or move towards admission in this way. And this is the biggest point. This is your patient. You should be in and out of that room, reassessing as they get treatments, reassessing their vital signs, checking on them, making sure they don't need more pain meds, or if they do, making sure that the resident knows so that they can order those for the patient. If they're getting sicker, you're telling the attending or the resident, just always be in that room until you get to dispo. Whether you're discharging or admitting that patient, just keep on reassessing. It's your job to look at the labs and imaging as you go, because this, again, is 100% your patient. And that will really show your attachment to this patient and how you go about the reassessment and bringing them to that disposition is really the sign of how well attuned you are to your clinical prowess in the emergency room. And then finally, at the end of your shift, try to do this a little bit before sign out or at the end of the shift, maybe an hour before. Ask for feedback. I would always preface every shift I was on with, hey, at the end of the shift, I would really like to get your feedback. I have this evaluation for you. And hopefully for the last hour, if we're not too busy, we can sit down and talk for 5 minutes and I can learn how to do better next time. Ideally, they give you things to work on. And then the next day that you're back, you incorporate that feedback. During the day, if you get any feedback, it'd be super helpful if you could incorporate that into your next presentation as well. It's a little difficult, but take the day to absorb everything, reflect on it, and then bring it to the next shift with you.
Also, I wanted to put in a plug for reflecting on shifts. This is something I'm definitely still working on. There are lots of things that happen in the emergency department. Some are cool, some are interesting, some of them can be honestly pretty sad. So being kind of attuned to what's going on, reflecting on your shifts, knowing who to reach out to, whether that be counselors, your residents, your attendings, your other medical students. Like, it's okay to be sad. Like, this is why you're human. This is what makes you a doctor and not a robot. So that's okay. And I feel like there's a lot of extra stress as a sub-I sometimes because you're trying to impress people all the time. But like, we understand you're human. Please take those moments to kind of like center yourself back because your wellness is very, very important to us. And also kind of focusing on the overall positives, but also taking away the lessons from the not so hot moments, but not trying to focus too much on those exact things that didn't go as planned, but more so take the lessons from that moving forward. Cool. So those are kind of our tips and tricks for on shift. And we could go a little bit more into other people's tips and tricks when we open it up to the rest of our panel and the rest of our attendees. But we wanted to do a quick plug for our sub-I. So if you are still looking for a sub-I spot, we have availability from like September onward. It's a little bit later in the season, but it can always be good to have one a little bit later just to kind of put your name out there, show that you're interested in either county or California or in Harbor in general. Something to keep in mind. And we would love to have you all. Just a little bit about our program. So we are LA County Harbor UCLA. I'll go into the other Los Angeles counties, but we are level 1 trauma center, level 2 peds trauma center, STEMI receiving. You can see all kind of our qualifiers right there. We serve a largely underserved population, about 60% Latinx, 18% Black, 11% Caucasian. You can see them. And over half of our patients actually have limited English proficiency. So we're lucky to have on the phone interpreters as well as in-person Spanish interpreters, which are fabulous. So this is always confusing to people, so I wanted to really clarify this, but there are 3 main programs in Los Angeles. And so we are LA County Harbor UCLA. So we serve SPA 6 and 8, kind of in this general region. We're in the South Bay of Los Angeles. There's also LA County USC, which now changed their name to LAG, or LA County General. That's kind of over in this area. And then UCLA has 2 sites. So they're a mix of county and academic, and they're Olive View and Ronald Reagan. So kind of those general areas. I'm kind of just circling random things at this point. But basically us and LAC USC/LAG are fully county programs. UCLA is kind of a fusion between the two. So it kind of depends what you're more interested in. But I think while you're going into your sub-I, seeing a little bit of like what a county program is like, what an academic program is like, because different people like different things. And also quick plug for the rest of our webinar series. So we have a few more coming up, and they're going to be about once per month. Next one is going to be how to apply to EM residency. It's going to be July 5th, 5 to 6 p.m. PST. If you have already gotten the link for the webinar itself, then you do not need to fill out this QR code. If you got the link for the Zoom from someone else, then I would definitely recommend scanning this QR code, making sure that you're on our email list so that we can send you reminders and Zoom links for these upcoming webinars as well. All right. Great. So at this point, I actually want to do some introductions for the people who are on the Zoom call from Harbor. So I'm going to just quickly run through everyone's names, and you all, if you're on camera, you can kind of wave real quick. But we have Naresh. He was presenting a little bit earlier. He's a PGY2. I'm Joyce. I'm also one of the PGY2s. We have Dr. Ryan Pedigo. He is our upcoming program director. Next up, we have Brad McIntyre, also PGY2. Dr. David Tannen, he's one of our APDs. Dr. Denise Whitfield, one of our wonderful attendings. John Warren, one of our chief residents for this upcoming year, PGY3 going on to 4. We have Leolia Hopanissian, also one of the PGY2s, and one of the co-chairs for the DEI committee. We have Dr. Teresa Liu and Dr. Kabir Yadav, also on joint screen. So we have some representation from different parts of our department, program leadership. So we are here and ready to answer any of your questions. We can also just keep blabbing more about Harbor because we absolutely love it here. But if anyone else on the chat has anything to add to those comments or has other advice, please feel free to unmute and go for it.
Hey, I have a quick question. I know Ryan wants to go into a couple of things. I'm Dave Tannen, one of the APDs. I just want to say a lot of sub-Is have a question about how many patients they're supposed to see. And I know Ryan alluded to in the chat, obviously Joyce talked about it, but you know, when I'm on as an attending, I tell at the sub-Is that I expect them to see up to 3 patients at once. That can seem like a lot or a little, but it's a nice amount. But it may be 2 patients at once because we also want the sub-Is to go to all the bring back nows and traumas and also be available for any procedures. So we don't want you overwhelmed with patients because we want you available for those other things, but we also don't want you sitting around and just staring at a screen. So after rounds, we have these tremendous rounds that we do where we talk about all the patients that we're turning over. At the end of that, especially with the sub-Is, I try to go over expectations of what the sub-Is should do. And it's just a nice guideline to think that, you know, if you're seeing 3 patients, you're on the ball and stuff like that. If you're seeing 2 patients, but you just went to a trauma and a bring back now, you're totally fine. If you're seeing 1 to 2 patients, but you just did a suture repair or a paracentesis, you're great. So just to have an idea in your head about how many patients, and I say not for the whole shift, but at once that we see, because we do emergency.
Great, thank you so much. Other tips and tricks from people? Ooh, Leolia just put something in the chat that I definitely want to bring up. So part of our DEI committee, we are offering $2,000 scholarships to visiting medical students who identify as underrepresented in medicine, pretty broad definition. Thank you, Leolia, for putting the link in the chat. And if you have any questions whatsoever, harboremdei@gmail.com. Me, Leolia, and Natalie Hernandez, we monitor that email so we can get back to you pretty quick. So feel free to reach out directly to any of us. We are stoked to have these scholarships and stoked to support you all in your journey to medicine because it's super expensive, and we get that. Other comments from anyone? Oh no, is there a problem with the link? It's okay, Leolia will find the right.
Yeah, let me double check that and I'll send it over.
Thank you, Leolia. Pedigo, do you have any comments or anything to add?
No, I think everything you said was super important. So, you know, I was clerkship director for 5 years, probably written a few 500 slows. And so, yeah, I think really all those things are super important. I would say, like, you know, be on time, be engaged, never lie about like literally anything. And, you know, it's hard because as a sub-I, you need to be like eager but not overbearing. Like you need to be like punctual but not creepily serial killer early. Like so there's a lot of like you need to do like just right, like a Goldilocks amount of stuff. But you know, it's hard, right? Being a sub-I is actually really, really challenging. So I would say just you know, the most important things you can do really are like take as good of care of patients as you can and like get as involved as you can. And like that's the most we're gonna ask. We know you don't know everything, right? We know that you may have never actually sutured a live human being or something like that, right? Like all I expect is like that you take really good care of patients, you like, you know, read enough about emergency medicine that you have enough scaffolding where I can like teach you something, right? So it's not like just a blank slate. And you know that you're just interested in the patient care and the department. And honestly, that's enough to get you like a top third slow, like no problem. So you know, for me, I think the things that you know when I rate slows or wrote slows, which I haven't written a slow in like 5 years, but you know when I used to write a lot of slows, I think the things that like were common themes that got people kind of downranked were you know, if they were disinterested, if they were like clearly unprepared, or you know, if they ever lied about any aspect of patient care. Those for me, I think would be like the really big red flags. But honestly, other than that, I think, you know, like Joyce had kind of said early, like, you know, what you also part of this is like choosing the right place for you, right? So if you have a home rotation, not all programs have a home rotation. If you have a home rotation, try to do a rotation that like complements that experience, right? Because there's these huge academic centers, like, and there's county hospitals, there's community sites, right? And, you know, if you've never done a county rotation, right, do you know if you want to commit 3 or 4 years of your life to one? And for me now, you know, who's going to be making rank lists, and, you know, one of the things is like, does this person kind of like know what they're getting themselves into, right? So someone with like 0 county experience and like 0 like link to like our patient population or mission, like I might be like, like, you know, are we the right fit for them, right? Whereas if like someone clearly excelled in an environment similar to ours, even if you didn't rotate with us, if you rotated at Highland or LACUSC or LAG, whatever, or rotated at Emory or Denver, like, you know, I know that you'll succeed here because we have very similar environments, right? And so try to make sure that your selection of your sub-Is is appropriately complementary to what your home institution offers, if they offer anything.
Great, thank you. All right, let's try and wrap it up maybe in like the next 5 minutes. I'm always down to end a Zoom session early so you all can enjoy your evenings, extra 20 minutes, you know, living your best life out there.
You can feel free to like unmute, ask questions, put something in the chat, and any of us are on the call. I mean, you have such a breadth of experience here. You know, you have like, you know, we have multiple different residents, all with different training backgrounds. You have like ultrasound gurus, like research gurus, pre-hospital gurus, who was also the Obama's doctors, someone who's a PD for a very, very long time. So, you know, this is, yeah, this can be like a Reddit AMA kind of thing, you know, if you have any questions.
Hi, everyone. My name is Marlika. I'm a rising fourth year. I wanted to ask a quick question about getting involved in traumas. How would you recommend students get involved in traumas, and like what would be our role?
Great question. Anyone want to take that one?
Yes, I do think it'll change a lot based on like where you're rotating. And so I think the most important thing is like setting expectations and then also framing it with like your skill set. So, you know, if there's a blunt hypotense trauma patient, right, that's the patient where like a fast exam like hyper acutely changes your management, right? If you are not familiar with fast, that's going to put you in a really uncomfortable spot, right? Because you're going to then be like, there's going to be like a trauma surgeon, a trauma chief, a trauma junior, a trauma intern, a trauma sub-I, a trauma MS3. There's going to be like an EM attending, an EMR4, an EMR3. Like this is like a lot of people, right? So like if this is like your first fast exam, like maybe the patient is like 60 over 30, like is not like the right one to get involved in. You can always like help with exposure, like, you know, help cover that person up and prevent them from getting hypothermia and hypothermia induced coagulopathy. So exposure, like, you know, warm blankets, anticipating like, oh, this person needs a portable monitor to like get to CT. Those are like the always helpful things. And then the other things would really be based on like the discussion and expectations you have with your team and your level of comfort. So if you've done an ultrasound like rotation, right, and you're very comfortable with your fast exams, you're rotating from a place that does ultrasound really well, then actually, yeah, totally. You can ask like, you know, can I participate in this fast? And like, that's totally fine. Like, I'm totally okay with that. I might preface that saying, well, this is blunt hypotension and the evaluation of free intraperitoneal fluid like really changes the management like right now. So if you have any trouble getting the images, like, you know, this might not be one where I'm going to let you like try to do that for like 30 seconds or a minute. Like I might guide your hand with the probe, which I would not do under any stable patient circumstances. But definitely important to frame it with your team and absolutely go to all the traumas. But don't be surprised. Sometimes like trauma surgeons sometimes will have a preference if it's someone like crazy sick who's going to get thoracotomy, subclavian, like right-sided chest tube, airway. Occasionally they will try to like whittle down the room a little bit, because when there's like 20 people in a room, we have huge trauma bays, but they start to feel a little bit small. So
all right, Tilu and Kabir have a comment too.
I just want to chime in about the FAST exam. So at Harbor, we do the ultrasound a little differently, I think, than I would say vast majority of programs in the country. Many places, so the recommendation would be for you to really ask first, like, what is the practice here, and don't assume and don't jump in, just start doing things. Because, for example, for the FAST exam, we are somebody asked me this yesterday, and we are sticklers for the real indication for FAST exam, which Ryan just said it because he's so used to it, but I don't think everyone knows this, which is that you actually have to be a hypotensive blunt trauma patient, right? That's where it's helpful for patients. But in vast majority of programs around the country, it's actually used a lot more liberally than that for training purposes. It does not actually benefit the patients, right? But then, you know, if you go to any other program, they might be doing FAST exam on every trauma patient. And we don't do that. So then that would be something good for you to not assume, but like ask. So I would actually say, go into the trauma and ask your resident, hey, where can I be most helpful for this patient? If it's someone that, as we get the pre-hospital notification, and we know that they are critical and they are crashing, you may not want to be there like dangling your ultrasound probe, right? You just say, okay, hey, what should I prioritize? And your resident will be helpful in pointing to like, make sure you got your scissor ready, cut off like all the clothes if this person is not fully exposed, or like if there's no access, I think you can really be helpful in putting in an IO, or actually this one, there's gonna be a gazillion people in the room. The best thing for you to do is to watch from the outside. Otherwise, people might get stressed out and upset. So, I would just say every trauma is different. Every trauma attending is different. Every trauma team is different. Just ask your resident and they will help you out.
Yeah, definitely want to reemphasize, just ask questions. We're all here to help. Just feel completely free to ask questions. All right, Dr. Whitfield, I see your hands raised.
No, I just wanted to add, well, traumas are activated differently in different hospitals. So just kind of figure out what that system is, and then ask how you can be useful, which I think other people have said as well. I think I can remember being a trainee and my fear was always just getting in the way, which may have prevented me from getting in on some things that could have been useful. So I think, before the traumas come in, you hear that the alert is overhead, just asking your team, hey, how do you think I could be the most helpful in this resuscitation? I think that's really good. And then the other thing I think is that after it happens, and not just traumas, but any critical patients, I just remember seeing a bunch of things going on. And as a student, I was like, wow, all these things just went on, but I don't really know what happened. So once everything calms down, just really feel free to reach out. Resident, attending, I would encourage you to ask the attendings questions. I think sometimes students shy away from that, but yeah, come ask me. Say, hey, I was just in this resuscitation. What just happened? Can we sit down and talk about it? I think that would be a big star for a sub-I as well.
Great. And just to summarize some of the other answers that people put in the chat, is getting exposure is huge. So getting people's shoes off, socks off, pants off, getting blankets on, having your scissors ready, buying those like $7 trauma shears from Amazon and having them always on you, super helpful, because inevitably every single time we're always like, anyone have scissors? And then if you're like da 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 and you pull one out, we love it. And warm blankets, transporting patients, getting family contact information, all of those are absolutely wonderful tips and tricks. We had another feel free to also unmute at any time or keep posting questions in the chat. I think Leolia had a comment also, so I will pass it off to her.
Hi, everyone. Thank you for joining. I think two things that I wanted to mention is like I joined EM like very late, did a very late sub-I, and like it's very natural to obviously like have anxiety as you're going into this, but you're already doing all of the things, and the places that you go, including Harbor, hope people like do want you to succeed, so and like learn and have fun at the same time. The other thing I think is like really important to learn about like the kind of emergency medicine physician that you want to be outside of the clinical care, and like what other resources to provide, and learning about what local like resources are available to help care for patients, like whether it's things like food pharmacy, substance use programs, trauma recovery centers, and how those align with your values, and learning about the healthcare system that you're in. That's a huge component of our residency program and something that you will hear talking day to day. So when we talk about DISPO, integrating social history is a huge component of that.
Yes, absolutely. When Naresh was kind of going through the nitty gritty on presentations with patients, kind of like always think about that next step. Be like, does this patient have the resources to follow up outpatient, or is it better that they get admitted for X, Y, and Z? Throwing in that social commentary and like knowing that you've thought about it, also huge. So thanks, Leolia, for the comment. Other questions?
Hi guys, I have a quick question. My name is Clara. I just wanted to ask, I feel like on a lot of rotations that I've done so far, I haven't done an emergency medicine rotation obviously yet, but I feel like it's always hard to